Good morning, everyone, and thank you for attending the DCH Fee-for-Service Policy Question and Answer session. Our hosts today from the Department of Community Health are Brian Dowd and Catherine Ivey. This session will be recorded and available on DCH's YouTube site on or before April 15th, 2022. Please enter all questions in the question and answer box. DCH will answer as many questions as possible within the allotted time frame. All questions will be captured, and any unanswered questions will be addressed in the FAQs that will be posted on GAMIS's web portal on April 15th, 2022. We ask that you turn your cameras off upon entry to the room, and at the end of the presentation, we ask that you remain online to complete a survey. The survey will take 5 minutes to complete. Brian and Catherine, this session is now in your hands.
Thank you. We're going to go ahead and get started with some of the questions. Can everybody hear me okay?
Yes, ma'am, we can hear you.
All righty. We're going to go ahead and jump into some themes that were submitted, and we thank all the providers for sending questions in advance. That helps us in grouping the questions and not answering one question over and over if it's asked. So we've done a little of that, and we want to go ahead and start with a question that was asked about a new change, a very recent change to behavioral health service availability. So I'll start there, and then Brian, I'll read out the questions that are submitted in the Q&A box, and then you and I can both pick out some of the themes from the questions that were submitted in advance. So the major change recently to behavioral health services that impacts primarily fee-for-service Medicaid, the state plan Medicaid, is that in the past, fee-for-service Medicaid had to be provided, behavioral health services had to be provided through an agency. They could not be provided or delivered by an enrolled individual provider. So an individual licensed clinical social worker or licensed professional counselor, marriage and family therapist was not able to enroll in fee-for-service Medicaid as an individual provider. We changed that as of the 1st of January of this year, and as of January 1st, 2022, individual practitioners in behavioral health services can go ahead and enroll in Medicaid through state plan Medicaid, and they enroll under the category of service, and the manual is found under psychology and therapy services. And I think that's category of service 570. But it's psychology and therapy services. Now, what we knew in order to get this service, make it available as soon as possible, we knew that we had a number of individually enrolled practitioners that were enrolled just as private practice providers through the CMO only function. The care management organizations for years had been able to use independent practitioners to deliver behavioral health services. We were not able to do that in fee-for-service Medicaid. So that was opened up to allow that in fee-for-service Medicaid, and all providers who were previously enrolled just to work with CMOs in the managed care population were invited to join the fee-for-service Medicaid through an enrollment process that was abbreviated. And we provided, Gainwell on our behalf, provided a couple of trainings in February that showed providers that walked through individual practitioners in the process of submitting an expedited enrollment process to be enrolled for delivery of fee-for-service mental health services. So that said, please log on to provider notices, and that training will be available there. And please, Gainwell, correct me if I'm wrong, but I think I've seen it there. So any provider that was not able to attend the session live could go in and review the presentation there.
All of our presentations are loaded on our website at www.mmis.georgia.gov. You'll go to where it says provider information, and then from the drop-down, you'll select provider notices, and all presentations are available there for you. Thank you.
Danny.
Catherine, you want to go through some of the other, do you want me to go through some of the other ones that were submitted in advance?
Let's do, and then what you don't, I'll cue you up for what you don't read out, okay?
Okay, that sounds great.
Okay.
So one of the questions we got was about referrals for therapy. And if we could expand referring practitioners to more than just pediatricians. That is something we can certainly take a look at. We can take that back within our CIS and CISS program and look at the feasibility of who our referring practitioners are and what's allowed under licensure and state best practice. We also got a request from the same question to extend our prior authorization period from 6 months to 1 year, and any other way that the process can be streamlined. We'll be happy to take any suggestions you all have for streamlining. At this time, we won't be going to a year-long authorization for CIS, CISS, or ASD therapy services. We will be maintaining it at 6 months. A lot of states do 3 months. So we provide a pretty robust 6-month authorization period. And that's for clinical reasons to make sure the plan of care is progressing and that things are working appropriately within the therapy that is given. But certainly if you have other suggestions about the prior authorization process, feel free to reach out to us at the department. Tamara Wilson is the point person for that. You can always reach out to myself as well when it comes to policy issues.
The next one, Brian, we'll go ahead and we can both address this one because it's really been addressed throughout and is one of the themes of the Medicaid fair this year. So in anticipation of at some point the PHE ending and we won't have all of those authorizations that were allowed that were specific to the public health emergency, there was a question submitted about we had promised providers that no members would be dropped from Medicaid during the emergency. And one provider writes in and says that they've had several patients whose Medicaid expired within the last year. What we have seen is there were some Medicaid members who, for a variety of reasons, lost Medicaid eligibility, most often through SSI lapses, or they were no longer eligible for Medicaid through supplemental security income benefits. And so what has happened is some of those members have been moved into the Peach Care for Kids program because they did qualify for that, but did not qualify for continued SSI benefits. As those members are coming to our attention, we're moving them manually back into Medicaid. So please feel free to reach out if you find any of those members. And in the meantime, just know that they've not been dropped completely. At least we certainly hope not. We will definitely need to know that if they have been. But they may have been moved from Medicaid into Peach Care for Kids, which is the CHIP program for children whose parents have a little bit higher income than do the Medicaid parents. Brian, you want to add to that?
Yeah, so one of the things we did also talk about, thanks, Catherine. One of the things we did talk about in the unwinding session as well is there are a few valid reasons that people get denied, right? So it's not just everybody forever, because if a member moves out of state, they're going to get terminated here in Georgia. And that's so that they can get service in other states with that state's provider pool. Obviously, if someone passes away, they will be terminated from the system. We wouldn't keep people on who had passed away. Also, a member can actually request closure, and we will honor that request to closure. So a member could call up and say, hey, I don't want this program anymore for whatever reason, and we would honor that and close them out. And the fourth reason is if we have gone back in the eligibility determination, maybe there was a federal audit or some other kind of eligibility audit, and we saw, hey, you made this person eligible for Medicaid, and they never should have been eligible for Medicaid. They were over income at the time they applied, or maybe they're in age blind and disabled Medicaid and they're over resources at the time they applied, and they just weren't eligible to be in the program. We will terminate those folks because we would not keep our eligibility error ongoing. That person would be terminated and afforded notice. So just so you guys know, there are a few conditions, not for a lot of members, where a member could actually still lose eligibility.
Thanks, Brian. When a provider is approved for only fee-for-service, but the CVO was denied, how do we get the letter showing the denial? I'm not quite sure what that refers to, and that may have been addressed in the credentialing and verification workshop. We may have to go back to our provider enrollment unit and ask that question, and then we'll post it. Response.
I think it's best to just make sure that was answered, because I'm a little confused myself how they would be approved for fee for service but not CVO approved.
I know. Okay. Another one is an update of the fees charged for client and the per diem of nursing staff for skin care. Let's skip that one. I'm not sure what that is. All right, here's a good one. There's a question about HMS, which is our third-party liability vendor for private insurance. The question has to do with recoupments when the third-party liability or the private insurance is on the claim and the primary pays a zero amount. So if HMS recoups because of a primary payer, but the primary payer didn't pay anything on the claim, the question is, what is the recourse for the provider? Do we have a DCH staff member on the webinar that could answer that? Look down through the list of participants. Because there are specific instructions. I want to say it's the secondary insurance guide. Anybody from DCH want to raise your hand and take that question? Okay.
Brian,
Yes.
this is Debbie.
I was hoping you were there, Debbie.
I'm here. This really is an HMS, is a TPL question. But if the provider could possibly send us a couple of example ICNs, that would greatly help so that we can look at the documentation that came in with that claim and determine why that happened and if it should have happened.
Okay. That's a great suggestion. Who should they send that to, Debbie?
It should be sent to Marisol.
Okay.
And or Linda Woody.
Okay.
In the TPL area.
All right. You want to go ahead and give that email address?
Oh. Okay. I'm thinking that Linda. I apologize. I'm having to check.
You might be able to just put it in the Q&A box if you want to. If you can do that.
Okay, I will.
Would be able to put it. Actually,
will.
if we can actually have the provider reach out to the field rep, so that way we can actually cross-reference and determine if that claim did process correctly, because technically the primary insurance should be built first before Medicaid actually makes a payment on it. So if we made a payment before the primary actually made a payment, then and it's now recouping as such, then it would be valid, but we'd want to have the field rep to look at it first. And then if we need to send it over to Marisol at DCH or Linda, then we'll do that at that point. So you'd want to submit your contact us inquiry on the web portal and give us an ICN example and give us some verbiage as to what transpired. We'll do the research and then we'll escalate it as such back to DCH
Thank you
if
so
need be.
much.
All right.
From our Gainwell partner.
Thank you, Danny.
No problem.
There's another question in the mailbox that says this provider believes that COVID-19 vaccine administration is reimbursed at $40. And they say their remittance advice showed $4 deducted from the $40 as contractual. I think you're referencing a CMO claim. If you bill the CMOs and the reimbursement was not $40, you'll need to contact that CMO directly because they are correcting those claims that were not paid at the $40 level at this point. And so they just need to know which claim it was. So please, if it was a CMO claim, and I can't think why that would have happened if it wasn't a CMO claim, but particularly when you mentioned contractual, that indicates to me that the claim was to a CMO. If you'll go ahead and submit that directly to the CMO and let them know that it was, the $36 vaccination reimbursements are all fee for service.
You would have to send ICNs or contact GAMUS to look at that, and they can get to what the issue is, and they would certainly alert us if there was some systemic issue in the system. So again, utilize those provider numbers and provider emails that are available on the GAMUS website so they can do the appropriate research for those claims. Just make sure you got the ICN there.
Thank you, thank you. The next question has to do with a correction about the primary payment or the third-party liability. And this provider says it's not so much about what I thought it was, and it's more about the fact that the TPL information on the GAMUS site is not correct. And so the claim may not pay, but it's incorrectly denied because the person actually does not have a private insurance coverage. So in that particular case, that also will need to be reported up through Gainwell, through the GAMUS system. And then the provider rep can internally refer that to our TPL unit here at DCH. We have a vendor who checks third-party liability and private insurance all the time and scans insurance company websites, et cetera. There's some sort of a database they use that I don't know what the name of it is, but they scan it nationally. And so they do that on behalf of the Department of Community Health and the CMOs, by the way. CMOs.
Right, so
Go ahead.
I was just going to interject. So I'm assuming that the provider checked eligibility and there was a primary insurance indicated on the member's eligibility in MMIS.
Me too. That's what I was
But in
saying.
fact, they should not have been a primary insurance indicated because that service was terminated. So realistically, the DMA 410 should have been submitted to us, indicating all insurance, the identifiers for the primary insurance so that we can conduct the research to validate that the primary insurance was in fact canceled. And then we would then remove the primary insurance from the member's profile, which then would cause that member to be Medicaid primary. So technically, you'd want to complete the DMA 410 form. Those forms is on the website at www.mmis.georgia.gov, provider information, and then forms for providers. And if you move all the way down, you'll see that DMA 410 form.
Thank you, sir.
All right.
The same provider is saying there was no primary insurance indicated. However, Medicaid located an incorrect policy later that was incorrectly updated and recouped their previous payment. Again, is it an issue that just needs to be reported through a 410 form, Danny?
Yeah, they'll need to complete that DMA 410 form so that way we can reach out to the primary insurance and validate the coverage was terminated. And then
Okay.
we'll update the member's profile in MMIS to remove the primary insurance info. So that way the Medicaid member would now be a Medicaid primary member.
Thank you.
No problem.
And then there's another, what appears to be a TPL question. Why does a policy number show redacted? We may have to get back to you on that one. I certainly don't know. Danny, if you want to take that one, be my guest.
I'll step away from that one.
Catherine, Danny, we've had this question come up in the past about redacting, and we are not, or DCH is not aware of them redacting any information. So we're going to have to get some information, Danny, and reach out to TPL about this and get back with the provider.
Thank you both. Danny, you may need to take this one. What's the estimated time on a DMA 312 submission? I would imagine the estimated time to resolution of that, something submitted via the DMA 312.
Yeah, see, the DMA 312 is actually sent to downtown Atlanta to DCH, so we wouldn't have a time frame in that.
Okay. So that would be then when you request review from DCH of a denied claim, I suppose.
No, this is the coordination of benefits, third-party liability, accident information reporting form.
All right, so it's just a different way to submit to make the same submission, but that's sent directly to DCH, I guess.
Yeah, that's to inform the state that say for instance, if the member was involved in an accident, to let us know that there is for instance, the car insurance company could be liable and the member is actually on Medicaid. That's just informing us of that incident.
Okay. So we will have to go back to our third-party liability unit and get a lot of these questions answered.
What I'm clearly hearing from you guys, and I'm glad we've done this, is that at the next Medicaid fair, we need to have a TPL breakout.
We sure do.
Because I know we've had TPL questions in other sections as well. I believe, Catherine, you told me there were some in your CMO meeting, and I know I've had some as well in my other sessions today. So I think this is really helpful for us for knowing that we clearly in our next meeting need to have some dedicated time that is specific to TPL, and we'll certainly take that back.
Completely agree. In fact, the next few questions are again, the theme is TPL. So one says, if a fee-for-service patient has private major medical, does the major medical insurance usually cover primary care? And the answer is, it just depends on the policy, and those have to be looked at individually, but typically, yes. But they're all looked at individually to see what the actual coverage is when they're reviewed. So it seems like TPL is the theme of the day. And here's another one about the alignment between a CMO and the GAMIS site not having the same TPL information. And so that sometimes happens because the CMOs also have a validation process. And when they validate, they send that information to DCH, which then enters it into the GAMIS system, but there's a lag. There can be a lag there, or there can be the fact that it's got to be validated again to see whether or not the CMO information was actually the correct information or what we're getting from our third-party liability vendor is more accurate. So there can be a lag. Now, there's somebody who wrote in to say it's referring to filing extension.
I think that's back to the DMA 312 question. So
Gotcha.
I think
Okay.
we answered that. Let me answer one that was pre-sent in since we're at the end here. We got a question that said, and hopefully this person is on, who do we reach out to when we receive retro effective dates and our claims are denied by Gainwell for past timely, and we are within our 6 months of retro effective date and are having a difficult time getting the claim to be processed, even with proof of retro effective date. So as an old eligibility worker, you have 6 months to file from the point that eligibility was added to DCH. So even if it was eligibility was added a year back, you still have, it's not 6 months back from today's date. It's 6 months back from when the eligibility was added into the system. Now, if what you're saying is the system is not following those standards, we would need to see an ICN number so we could compare the ICN number versus when eligibility was added to the system. And again, you can just utilize the GAMUS email or call-in number to get that information. If it is something that needs to be escalated, the good folks at GAMUS would then escalate to us and say, hey, there's something funky happening with this case. One other thing I do want to say about this, because I get this a lot, as far as being so involved with Asd Therapy as I am, just because you have retro eligibility doesn't mean you have a retro prior authorization for services, right? So we won't go back and add PAs from 2 years ago because that's outside of our policy. And as providers, if it's a service that has a PA like Asd Therapy, you need to make sure your members who are presenting to you as private pay understand that, even if they have a pending Medicaid case. They need to understand, hey, I'm seeing you now, but I'm seeing you on a private pay basis. And it is no guarantee that if your eligibility is updated and goes back, I'm not going to have a prior authorization for services, and I can't get a prior authorization for services retroactively. It's right there in the name, right? Prior authorization. So you have to really kind of have that explanation with your members, because when they're presenting to you as private pay, and you're agreeing to accept them as private pay. Did we have anything else come into the chat box?
We did. We have a suggestion, and I think, Danny, you want to tell folks exactly what to do with the 312, the Form 312?
All right, so about getting the extension, when you build a claim, if it's a claim that's sufficient that needs to be billed to us, when you build the claim on the web portal, for instance, you would upload the completed DMA 312 form to the claim. So that way we have that documentation on file. And then also we're supposed to actually route it if it's attached to the claim to DCH for them to actually review it to help with that extension.
Thank you, Danny.
All right.
And Debbie, if you're still there, I may have to toss this one to you. And this is about an outlier claim. Our manual states that providers can't void a claim via the portal if they already have submitted an outlier request or an outlier claim. Sorry, y'all, this keeps moving on me. And the provider just wants to confirm that.
It's true. Once a claim posts the outlier 4399 edit, and you initiate the outlier request, then you cannot go back and void the inlier payment to make any changes to that claim. And once your outlier has been processed, if it's approved and you receive your outlier payment, you cannot void that outlier claim. The system is configured to not allow the providers to adjust that claim. It will deny your request. Those claims have to be sent in to DCH with a letter stating the reason for you needing that paid outlier claim to be voided. It is reviewed, and a response will be provided back to you.
Thank you, Debbie. There's another question about the addition of behavioral health providers. And this provider asks, will there be a policy manual specific to this type of providers? And will there be a billing section that would be specific as to what modifiers, et cetera? It's really, I think this is all about billing for an individual practitioner by an LCSW, an LPC, or a licensed marriage and family therapist. All of the codes that are allowable in fee-for-service are available and laid out in the psychological and therapy services manual. So if you go into the GAMA's website and scroll the manuals and you look for psychology and therapy services, all of the codes are there. And if there are modifiers, which I don't recall that there are, they would be listed there. Let's see. Somebody's talking about the 72-hour rule and/or late charges. We need to combine the charges. With new charges, claim now qualifies for a higher outlier amount. I can't really speak to that. Debbie, if you can or want to, please feel free.
Okay, if you're referring to a paid outlier claim, and for some reason, due to the 72-hour rule, you had not combined the charges, then that is one of the times that you will send that in to DCH with your written letter explaining what has happened and why you need that outlier voided.
Thank you, Debbie. There's a general question about the Medicaid fairs, and this person asks, when will the Medicaid fairs be held in person again? And we realize that this is a difficult forum, this virtual forum. It's much different than having all of us, in the same rooms and being able to just talk informally and formally. And so there's an expectation that the next Medicaid fair will be in person, but you all know that all of our lives have been absolutely not only influenced, but surrounded by the requirements for social distancing. So it all depends, but we anticipate that the next Medicaid fair will be in person. And Brian, you might want to take this one. This provider says that she works for an ABA center. What form is she to submit if she's submitting an authorization for a child who's 5 or older, but attending ABA full-time rather than enrolled in school?
Thanks, Catherine. So we authorize therapy in ABA based on medical necessity. We don't supplant school services. And we don't pay for what would otherwise be covered under the IDEA Act. So we don't pay for education out of ASD therapy. ASD therapy is just like OT-PT speech therapy. They are targeted intervention therapies. They are not meant to supplant school services. So there's not a separate form. You would fill out what your requested hours would be based on medical necessity to receive services to correct or ameliorate the child's condition. We don't, and it's not even clinically sound that a child would receive 8 hours of therapy in a day. It's not something that is clinically allowable. So again, you would just You would submit as you normally would for however many hours of therapy, but we're not going to use the therapy to supplant school services.
Yeah, and I'll just add, because I'm really fond of saying, state Medicaid agencies don't control everything about Medicaid. That's a federal law that Medicaid not be used to supplant other federal fund sources. So there's some things we can control and a whole bunch of things we can't, and that's one of them. So one provider says, are we able to upload an IME form through Gamewell? I'm sure you're referring to an incurred medical expense form. That has to be done through Gateway, I believe. Correct me if I'm wrong, somebody. Because that's related to Medicaid copayments or provider copayments and specific to long-term care services, that has to be uploaded to Gateway system. And one provider says, if Medicaid is retrodated and a PA was required for a service, but the PA wasn't obtained due to Medicaid not active at the time of service, do we have to bill Medicaid? I think you're saying that you would want to bill Medicaid, but you didn't have a PA for it.
So, yeah, I think this goes back to what I said before. It's important when you're having a conversation with a member when they present. And you could actually do this for a Medicaid member, right? There's rules in the Part 1 policy manual that allow you to have a Medicaid member pay private pay. They just have to sign off that they're essentially ignoring their Medicaid benefits, and you have to provide other available providers to them as an option rather than you prior to accepting them as fee for service. But if they're not a member for us, a person off the street comes in and says, hey, I have Medicaid. You're accepting them at that time as private pay, and your relationship with them is private pay. You will not be able to get a PA retroactively. In most of the instances, we do go back 30 days in ABA therapy in our Asd Therapy program. But in most instances, you won't be able to get those retroactive PAs. So you will have to have set up a fee-for-service arrangement with them.
Okay. One provider gives us some information, and she says that typically providers have 6 months from the retro effective date shown on gammas to get an authorization. And she thinks that the information is shown in the physician services manual. She says there's an option to select retro eligible member when submitting the authorization on gammas.
Thank you. Yeah, that is really helpful. I think what we've seen from the Q&A is that maybe some of the concerns are related to CMO, and I know there was a separate CMO section, and there being a differential between the prior authorization for CMO and fee for service. So we will certainly bring that back to our CMO ops meeting to discuss. So hey, that's really important, and I'm glad you guys brought that up.
We always learn as much from you all as we do from anybody, anyone, because you all use Medicaid every day, you bill it every day, so you tell us what's not working. There's another question that came in that says, can we bill the patient without an ABN for a retroed Medicaid? PA was not obtained due to Medicaid not active at the time of service. I think that may be pretty much the same question as above. Typically, RetroPAs are only allowable if the Medicaid has been retroactively approved. So clearly, you couldn't get a PA when the person didn't have a Medicaid number to request it through. So if you're having trouble with that with a CMO or with us, just let us know. There's another question about outliers. This provider says, I understand the process once an outlier is paid, but what if it's denied? Are we allowed to have any recourse to submit a denied outlier?
Okay, if the outlier request is denied, that would be denied by Alliant. And so any appeals for that review would have to go through Alliant. I know they do have an administrative review process. So depending on the reason for that outlier denial, you should be able to do an administrative review through Alliant.
Thank you, Debbie.
Do we want to pull a line in on that question so that way they can piggyback on it?
Are they here, Danny?
They are.
Oh, yes.
Hi. Yes, if an outlier has been denied, you may submit a second request on the outlier and attach any additional documentation, include a cover letter as to what you're appealing for the denial. And as I said, if the denial's for missing documents, be sure to attach that.
Thank you, Devlin.
Thank you.
Right in the nick of time.
We want to address also the RetroPA question also, so that way we can have clarity with the providers on the RetroPA, Devlin, please.
Is Lee on by chance?
I think we did.
I really think the PA question is more related to Asd Therapy, and I can clarify that we go back 30 days, but we don't go back more than 30 days.
Okay. Thanks, Brian.
Okay, we can continue. I don't think Lee is on.
Another provider says that they've had some patients retro enrolled in a CMO. Why would a patient or a member be put in a CMO retroactive? We have seen that as well. And if the member was rocking along with a fee-for-service eligibility, such as supplemental security income, SSI eligibility benefit, and that qualifies them for Medicaid, and something happened to the child's, if this is a child, which I'm presuming it is, something happened to the family income. Something happened that caused the income to grow to the point where the child was not eligible for SSI. Then, because we are not terminating any Medicaid during this time, the member, the child, would be placed in a CMO retroactive, because clearly we don't have a federal designation any longer for fee-for-service Medicaid, but we don't want to terminate that child. So we place them in a CMO. And often we don't get SSI denials until after the fact. So we do, as a state Medicaid agency, receive retroactive SSI denials pretty frequently. And again, because the child needs continued coverage, the child falls into, I use that term loosely, but they're placed in a CMO so that we don't completely deny coverage. The next question says, we're serving members in private home care and waiting on Medicaid approval. Are we still eligible to set up retro?
Yes, that's a different scenario. So you're in the waivers, you have a plan of care for service, and you're waiting DFACS to approve your case. You will still have a PA out there for those services based on the plan of care. It will sit out there until the member's eligibility is approved.
And then the next question we're going to toss to you, Debbie, to explain what an outlier claim is.
Okay, an outlier claim is an inpatient hospital claim that has the cost have exceeded the threshold for that particular DRG, and the system posts the edit 4399. to allow the providers to initiate an outlier review request, which requires itemized charges and all types of documentation that are outlined in the Hospital Services Manual.
Thank you, Debbie.
Mm-hmm.
I'm not seeing.
Catherine, there's a couple more from the spreadsheet that I don't think we've addressed, so I'm going to go through those real quick.
Please.
Most of them we have, and again, there were a lot of questions about TPL in the pre-submitted questions. But there's a couple of that seem to be a little waiver related, and one is adult day center the same as assisted living? Catherine, I'm going to let you answer.
All right. One more time, Brian. I just need to make sure I understand the question.
Is an adult day center the same as an assisted living?
Gotcha. Thank you, Brian. In the waiver programs, those two services are different. They're distinctly different. An assisted living facility is called by various service names and various waivers. In the now and comp waiver, it's referred to as community residential services. In the elderly and disabled and the ICWP, a residential setting that serves folks who need round-the-clock supervision and some support and meet the waiver level of care is called alternative living services. So each of those residential services that are roughly the same go by slightly different names depending upon the waiver program and the population served. The Adult Day Health Center is a day center that offers no residential care or support at all. And it has a separate licensure status. Adult day centers are licensed by healthcare facility regulation by that name. And the residential settings or the residential services are licensed either as personal care homes or they're licensed for the developmental disabilities population as community living arrangements. So they're entirely different licenses depending upon the service.
Thanks, Catherine. I got another question that is kind of eligibility related. It says, why do we approve patients for QMB Medicaid when they do not have Medicare? We shouldn't. No, QMB Medicaid is that's qualified Medicare beneficiary. It's only a type of Medicaid that we should be assigning to individuals who have Medicare. So if we have done that inappropriately, which would be odd because we do have to verify Medicare eligibility before making those folks active for QMB. Now, it is possible they lost their Medicare along the way or whatever, quit paying their premiums, and so it got turned off before the state started paying the premiums. But you should certainly know that you can't process claims, because that's the second part of the question, for somebody who doesn't have Medicare if there's QMB Medicaid. QMB Medicaid only pays for the 20% of hospital bills and doctor bills that Medicare doesn't pay for. It does not pay for non-Medicare covered services, and it does not pay for the portion that Medicare does not cover, and it actually has to have the crossover to work. It's a good question. I hope there's not a lot of those, because I don't know why we'd be making folks eligible when they don't have Medicare. I think everything else that is in, I know we're coming up on time here with 10 minutes. And yeah, occasionally patients do stop paying their premium, and that is a shame. That just came into the box, because if they would have waited till the QMB, Slim B, or QI1 was approved, then, we would have picked up that Medicare premium for you. So it's also always good to remind folks that that is an option in eligibility. So thank you for that question. That's a really good one. I think that's it for our questions in the pre-submitted questions, and I'm seeing we're kind of at the end of our questions here. I believe Sharona and Gamis wanted to put out a questionnaire at the end of or a survey at the end of this session. Is that correct? Great. So here are your poll questions. We're going to use this 5 minutes before now and the end of the session, since we're kind of through our Q&A, for you guys to go ahead and rate you. I'm just going to put myself on mute and give you time to go ahead and do this poll session here. Thanks you all so very much for attending the meeting and continuing to be so interactive with us here at the department. Any questions that we miss, we will certainly be following up in writing. Thank you, and have a good day.
Thank you. Thanks everyone for attending today. If you would please complete the surveys, please, before exiting the room.